Mr. Chairman, thank you. It's my pleasure to present the position that all bifurcations fulfilling the definition 2 criteria should be stented with the DK crash technique in this year's controversies at EBC 2021. So how were the definition 2 criteria devised? They came from a definition study published a few years ago, in which case a training group and a study group were utilized to define criteria, and these were the criteria that were eventually defined in Major 1 and Major 2, depending on whether it's a left main or non-left main bifurcation of diameter stenosis 70% or 90%, depending on which, and in both cases, lesion length greater than 10 millimeters, and any 2 of 6 minor criteria. So this defined a high-risk patient who had a worse outcome in that particular study. This informed the design of definition 2, in which case 660 patients with complex bifurcation lesions were randomized to a provisional strategy or a 2-stent strategy, with clinical follow-up being at 12 months, angiographic follow-up at 13 months. Important because that did not confound the clinical outcomes. So if we were to look at some of the highlights, a complex group of patients, as you can see, mean syntax score 24 in both groups, syntax 230. So these were both angiographic and clinically complex patients, in which over a quarter of the patients actually had a clear recommendation based on the syntax score 2 for bypass surgery, a long lesion length of 20 in the side branch, 40 in the main vessel. So very much a complex group of patients. Procedurally, the majority of the patients in a 2-stent group were treated by the DK crush technique, some with culotte, very few with TAP. In the provisional, it was mostly of course, 1 stent only in the majority of patients, with those who were treated with a 2nd stent in the side branch. TAP and culotte were primarily utilized. In terms of results, a clear benefit demonstrated for the 2-stent procedure, the majority of which, of course, was DK crush. In terms of TLR, target vessel MI, target lesion failure, significant result with much lower event rates in all of these outcomes for the 2-stent procedure. Now we have other data as well. In DK crush 5, the patients were analyzed by complexity, in this case by the NAIRS score and the syntax score. However, if we look specifically at the definition complex and definition simple definitions, we see a clear separation here with a significantly lower event rate in terms of target lesion failure in the DK crush group specifically compared to provisional stenting. But we also see a trend in the definition simple group. So there is, I would think, some evidence that both groups may benefit. In DK crush 3, compared to another 2-stent procedure, we see MACE rates at 3 years in the complex group with DK crush 15.1%, all the way up to 51.5% in the culotte group, highly significant difference favoring the DK crush group in the complex subset. Just briefly, the European Bifurcation Club left main, somewhat different, but a very important study. But clearly these are not definition complex patients with side branch lengths under 10 millimeters in both groups. A wash, similar results in both the stepwise provisional and systematic dual approach. The techniques that were utilized, interestingly, were very few DK crush, mostly culotte in the systematic dual versus the stepwise provisional. DK crush, in spite of the fact that these patients were enrolled between February 2016 and November 2019, long after publication of DK crush 2, DK crush 3, 3-year data from DK crush 3, as well as DK crush 5. The DK crush simply was not adopted, I believe, in Europe in any way. Nonetheless, I think we do have to validate the technique in other populations and ensure that other investigators, other operators can do this as well. So we are actually launching a Access 1, which is a Pan-American randomized controlled trial of DK crush versus provisional stenting strategy in patients with not quite as complex lesions as in the studies previously suggested, somewhat less complex, but still complex lesions, side branch lesion length greater than 5 millimeters, amongst other characteristics. So in conclusion, until proven otherwise, Mr. Chairman, panelists, the DK crush technique is the preferred technique and provides the best results for patients undergoing PCI of complex definition type true coronary bifurcation lesions or less complex true bifurcation lesions until, again, proven otherwise by new data from other studies. Technique is critical. Prepare meticulously and pot. Say this twice because pot is essential after each crush, and really everyone can do this. This is has a number of steps, but is not a complex, difficult procedure. Mr. Chairman, thank you very much.